first case is a 2-year-old female with history of button battery ingestion who presented with new symptoms of emesis and dysphagia to solid foods. An esophagogastroduodenoscopy was done at that time and demonstrated a complex, irregular, benign-appearing, intrinsic mild stricture comprised of 2 levels of diagonally traversing mucosal tissue. Due to the complexity of her stricture, we chose to first perform endoscopic incisional therapy to cut the more proximal layer of mucosal tissue. This was done to widen the luminal diameter and make a straight stricture that would be more amenable to balloon dilation. We used a bipolar probe for coagulation and cauterized the tissue with multiple radial incisions. Following cauterization, we used a through-the-scope balloon dilator to dilate the stenosis to 10 millimeters. The second case is a 1-year-old male with a benign, severe intrinsic stricture as a result of prior repair of congenital type C esophageal atresia with tracheoesophageal fistula. The initial endoscopy demonstrated a stenosis 4 millimeters in diameter that was not able to be traversed. Over the next 4 months, he underwent 5 additional dilations, as well as intralesional steroid therapy without improvement of his symptoms or esophageal stenosis. This was due to the mucosal fibrosis on one side of his esophageal mucosa, as demonstrated here at 3 o'clock. In this case, we used endoscopic incisional therapy to cauterize the area of fibrosis to widen the luminal diameter laterally, where it was previously firmer than the rest of the strictured esophageal mucosa and resistant to balloon dilation. Following incisional therapy, we used a through-the-scope balloon dilator to dilate the stenosis to 10 millimeters. This patient then underwent an additional dilation 4 months later, where incisional therapy was not needed and the stenosis was able to be dilated to 12 millimeters.